All right, why don't we go ahead and get started? I know people are still joining us, but first of all, I just want to wish everybody a happy Friday. Thank you all for joining us today. Multnomah County Chair Deborah Kafoury and I are very pleased to be hosting this public-facing dialogue about behavioral health issues facing the Portland metro area. These are dialogues that I announced during my State of the City speech earlier this spring, and I'm deeply appreciative of the chair's partnership in bringing this to fruition. I hope this will be a very informative as well as a lively discussion. As I think everybody on this call is probably aware, Oregon consistently ranks near the bottom of most lists based on the rates of mental health problems, as well as access to care at the retail level. Our mental health system is ranked 49th in the nation, and we now have the highest rate of meth use in the entire country. That's not to say there's not a lot of good work that's gone into addressing these issues over the past few years. There certainly has been, and we're going to hear about some of that good work today. But we also come together acknowledging that there's still much more that can and must be done. We've invited some of our key legislative partners here today in hopes that we can educate the public and each other around the local crisis response system, and that we can come together and work together to do more to support those experiencing mental health crises in our city and throughout the greater metro area. And with that, I'll introduce Chair Kafoury. Good afternoon, Chair.
Thank you, Mayor. And I also want to thank everyone for joining us this afternoon. This is such an important topic which touches the lives of people throughout our community. I don't think it's a stretch to say that most, if not all of us, are impacted in some way by substance use and mental health disorders. And that might be in the form of a family member, a friend, a coworker, or people maybe living with it themselves. At Multnomah County, these issues touch on so much of our work. Our employees see the devastating effects daily in our health clinics, in our shelters, and in our jails. But we also hear stories of hope. When people can access care and treatment, we see health regained, we see recovery. But we know that that's not happening enough for enough people. One of the pieces where we can build on a foundation of success is our behavioral health crisis system. Every day, thousands of dedicated and committed professionals go to work trying to help people experiencing a mental health or substance use crisis, sometimes both. We know that there's also a significant need for more treatment resources and housing to help individuals after a crisis. But there will always be a need for compassionate, trauma-informed, and well-trained individuals who are able to help someone during the most challenging times in that person's life. And this type of work can't be accomplished by any single government or organization. It takes extensive partnership. And I'm glad that we're joined today by people who represent that partnership. I especially want to thank Representatives Nos and Sanchez for their work on behavioral health. In my decades of public service, I have never seen such a level of interest and commitment by the legislature. And I'm looking forward to even more being accomplished in this upcoming session. So we're going to hear from a number of people today, and I can think of no one better to help facilitate this conversation than Multnomah County's own Ebony Clark, the director of our health department. She brings decades of experience in behavioral health and is an expert in the field. And with that, I'll turn it over to Ebony.
Thank you, Chair Kafoury. Thank you, Mayor Wheeler. Again, Ebony Clark. My pronouns are she, her, hers. I like to just kind of set the tone and just also acknowledge that this conversation is timely, especially as we begin to climb out of the pandemic and everything that we're seeing and experiencing and having to navigate and respond to. I also want to highlight and remind folks that the topic of behavioral health is vast and broad, but this evening we are specifically going to be focusing on our crisis continuum of care. Also want to remind everyone that this is a webinar style meeting. There were prior opportunity to submit public comments and questions, and what we attempted to do was integrate those questions into today's presentation. And for our panelists, I kindly ask that you remain muted unless you're actively presenting. And so with that, I like to pass it on to Julie Dodge, who is the Interim Behavioral Health Director for Multnomah County. Julie, please take it away.
Thank you, Ebony, and thank you, Mayor Wheeler and Chair Kafoury. Again, my name is Julie Dodge, and I use she, her pronouns. Justin, can we bring up the slideshow? So I go on to the next slide. So my role here today is to provide a system overview of what we mean by crisis, discuss the continuum of crisis services, and then we're going to turn to three of our key partners in Multnomah County who will talk about who they are, what's working, and opportunities for improvements, including Portland Street Response, Project Respond, and Unity Center for Behavioral Health. Next slide, please. The big question here is, what crisis are we talking about? We recognize that when we talk about crisis, not everyone is thinking about the same thing. At the system level, we have been challenged by workforce shortages, limited access to the kinds of services that a person might need both during and after a crisis, critical issues at the Oregon State Hospital, surges in new kinds of substances like methamphetamine and fentanyl that cross the silos of substance use and mental health needs, and continuous change in how our systems are funded and coordinated. The public has been overwhelmed by what they see and experience both in their personal lives and on the street. The interface of houselessness, mental health, and substance use is significant. There are suggestions that more people with significant mental health and substance use are living outside, with estimates ranging from 12 to 50% of those living outside experiencing one or more behavioral health condition. The public interprets this as a crisis, and when they encounter persons who are manifesting behavioral health symptoms, they consider that an emergency. Well, in terms of the actual person who's experiencing a behavioral health crisis, we define that as someone who is presenting imminent danger to themselves or another person. They aren't able to care for themselves, or they are talking about suicide right now or harming another person right now. Next slide, please. When it comes to all of this, then it comes down to, well, who's responsible for this? The city, the county, the state, the feds, the nonprofit organization, who is responsible? In terms of the city's role, I mean, we really overlap, and we have specific roles in the system. In general, the city is responsible for public safety and should be ready to intervene and offer options to protect the general public, as well as individual members of the public. This includes, but is not limited to, law enforcement and fire. And then the county, as the local mental health authority, is responsible for the oversight of the safety net, which is that thing that hopefully catches all the people who aren't able to access support and services, and our crisis service continuum. We convene and collaborate with partners throughout the county to develop an accessible and efficient system of care for anyone impacted by behavioral health challenges, prioritizing persons with no access to resources and historically oppressed and underserved populations, specifically Black, Indigenous, and other people of color. Next slide, please. So going back to this behavioral health crisis, an individual experiencing a behavioral health crisis is dealing with an emergency situation. Their life is at risk, or perhaps that of another person. And the response to this crisis requires a consistent, intentional, and well-coordinated systemic response. It shouldn't be random, and we shouldn't be trying to figure out what's happening in the moment. Next slide. Here, what we start to see is that a well-coordinated system is about more than just one thing. It requires prevention. And I know there's a lot of words on this slide, and some of them are hard to read, but there's a lot of things that happen to make up a consistent, coordinated system of care. In terms of prevention, that includes everything from housing and employment to access to healthcare, as well as crisis planning. How do we prevent crisis from happening in the first place? That leads us to early intervention. When someone is beginning to escalate or have difficulty, being able to identify them early through outreach, family and community support, those actions can help preempt an emerging crisis. In terms of a response, this comes in the emergency response when we really do have a crisis happening, and includes mobile response, voluntary access, and periods of stabilization. And we're going to hear more about those specific services because we're going to focus on that specific quadrant today. And then afterwards, we need to have a system that is able to address the what next. You know, crisis stabilization is very brief. Postvention, or the what next, can include peer support services, making sure that people have access to appropriate level of treatment and supports, including medication and care coordination. Next slide, please. When everyone is seeing the systemic and public crisis, lots of folks want to get involved. This includes public entities like the state, city, county, federal government, as well as private nonprofit organizations and care coordination organizations. We all see the challenges. We all want to help, but without clear coordination and collaboration, the system gets muddy and unwieldy. In Oregon, the state has designated the local mental health authority, which is typically the county, and which I get to serve as your key director for, is responsible for the oversight of the local crisis system. There is a policy opportunity to assure that all entities engaging in crisis services and the safety net coordinate with the local mental health authority. This would lead to single plans for services, clear lines of authority, and reduce the risk of duplication and competition. A specific aspect of assuring a coordinated system looks at how the public is able to access crisis services. Who do they call? 911, 988, the county call center. Multnomah County has operated a 24/7 call center for over 20 years. In 2022, we received over 100,000 crisis calls, the most in our history, and a 30% increase over just last year. Our well-established system allows us to connect people to their existing providers, coordinate crisis alerts across the entire crisis system, and dispatch mobile crisis, among many activities. Less than 7% of the crisis calls result in the call center referring to Project Respond or Portland Street Response. You can see that the vast majority of contacts here, I got a quick summary in the middle of what Project Respond does. You can see that the vast majority of the contacts they have lead to a community-based plan for support and care. What that means is that the person stays in the community. They don't need to go to the hospital. They don't necessarily need to go to a more acute space. They're able to work with Project Respond team to safely manage what they're dealing with in their current location or with the appropriate support. And this can include some brief follow-up by them. And less than 8% of the folks that they respond to are directed to a hospital or to acute levels of care. For those of you who are unfamiliar with the director's custody hold, this occurs when the team determines that a person may pose an imminent threat to themselves or another person, but they are not willing to voluntarily seek treatment. The ability to initiate a director's custody hold is delegated directly by the director of the local mental health authority. Essentially, they are acting on my behalf. So I take that very seriously. And we think about what are the impacts of, and how do we assure that that is a coordinated and effective use of authority. I also want to call out on the data for Portland Street response that you see here. We know that a challenge in our Portland Street response referrals, as noted here, because we only began reporting on that the beginning of January, because Portland Street response is, somewhat new. I mean, they're a year and a half old. I mean, it seems like they've been around for a lot longer, but it's a short time. We only began capturing that data in January of this year. And in the first quarter, we had 29 referrals, but that grew by 11-fold to 329 referrals in April to June. But Portland Street Response gets the majority of their calls from 911, though many of the 911 calls are also being transitioned to the call center. This creates or reflects a challenge in coordinating mobile responses, data collection, and outcome tracking. Add another layer. 988 is a welcome addition to the crisis continuum of care, and they have been tasked with offering many of the same activities that the county is also currently required to do. And we have a well-established model. So our opportunity that we think about is when we consider actions to expand and improve our crisis services, we want to consider what is already being done and its effectiveness, and work collaboratively to find solutions that provide the public with easy access no matter who they call. When we talk about federal and state legislation, we want to build into that legislation opportunity to allow local entities the ability to adapt and respond to those legislative actions as it best meets the need of what's already there. We don't want to dismantle or duplicate or, what's already working, but we want to build and improve on what we have. Across the state, the urban setting is different than the rural and frontier settings, and each requires a modified response. And I'm going to end my portion for this moment to say that, two opportunities from a policy and legislative space is to assure that we have in our local jurisdiction clear oversight of the crisis system, and that we can work on coordinating dispatch and access for crisis services so that we aren't stepping over each other. We have a better sense of who's being served when and by whom and for what reasons. With that, I'm going to pass over. Ebony, I think you're going to introduce Portland Street Response. Next slide, Justin.
Thank you. So my role today also is to be timekeeper and to also facilitate dialogue. We have about 11 minutes for any additional questions or comments before we go to the next presentation. Julie, I want to thank you and appreciate your presentation. I'm a believer that it's important for us to really understand how our continuum is upheld and supported. Oftentimes when I talk about our local continuum of care, specifically the behavioral health continuum of care, I like to think of 3 pillars where we have the state, specifically the Oregon Health Authority, and then we have the counties, which fulfills the functions that Julie spoke to, specific to the local mental health authority and the community mental health program. And then we have the coordinated care organizations. We have 2 of those. We have HealthShare that predominantly supports and oversees the Medicaid benefit for residents in Multnomah County. And then there's a small portion that's supported by Trillium CCO. And it's important to understand how the systems are interconnected, while then also interfacing and working with our city partners, with our hospital partners, and our community-based organizations to provide services. It's also important to be mindful of how the services work together, so that then as we work to enhance and improve, we're not creating risk or potential for fragmenting or siloing. So thank you for the presentation, Julie. Before we move forward, I'd like to take a moment to see if there's any questions or comments that our panelists would like to bring forward. Mayor Wheeler.
Yeah, thank you. And let me lower my hand before I forget. I always forget to do that. Julie, thank you for the presentation. That was actually excellent. And hopefully that's what was just emailed to me. I'd love to get a hard copy of that. That's something I'd like to pass around to some other folks as well. So you mentioned data collection, and that's near and dear to my heart. We have been hearing a lot at the street level, certainly at the law enforcement level, about fentanyl related deaths. That's been fairly well publicized. Fentanyl related deaths are up about 108% just over the last 3 years. And from where I sit, it appears to continue to be rising basically out of control. Do we have any data that we're collecting, or can we collect data around the use of newer, more potent, and more destructive substances like P2P meth, or some way to potentially estimate the use of those substances?
So really, I mean, when we're tracking overdoses, that's really the work of the public health officer. And, you know, those are captured. I'm looking right now at the 2021 data that, you know, we see an increase in any stimulant. What I can say, we have a definite increase from 2021. In 2020, we had 188 stimulant overdose deaths. In 2021, we had 289. So that was 100 more people. So that's a 33% increase. But that is any stimulant. I don't have the specific data on methamphetamine, but I think we can look into. It is kind of difficult though to tease out, is this meth P2P? What form of fentanyl? I mean, we can test to see what a person has taken, and then, you know, if they happen to have that substance on them, then we can identify it. But if they don't have it on it, it makes it a bit more difficult. I think what we honestly need to be able to recognize is that substances are going to continue to evolve and shift. And it really, I think we need to know these things are happening and work on how do we reduce access to those, but also investing in healthy communities and doing some of the prevention work so that people aren't using these substances in the first place. But yeah, I mean, I think I could ramble about things. I won't.
Yeah, and I understand the complications there. It's just, it's clearly a dynamic, and we're seeing it not just here in the city of Portland, but we're seeing it nationwide. And these newer, more refined, deadlier substances appear to be taking up a larger percentage of our first responder workload. And so if there is some way we could work together to potentially develop the data set to be able to measure that, I think that would be really helpful for us, because it's you know, based on what we know, it appears that the use of these more dangerous and impactful substances are rising fairly dramatically, and that obviously has implications for our you know, not only our upstream treatment and prevention operations, but also at the street level in terms of enforcement and maintaining public safety. Related to that, do we have any sense of what portion of the calls that we're receiving are high acuity compared to, say, 5 or 10 years ago?
Yeah, to be honest, it's remained fairly consistent in terms, but the volume has increased.
And
so
the percentages are remaining the same, but the gross number. And can you give me some sense of the growth in the number?
So prior to the pandemic, we were hanging pretty steady for the couple of years prior to that, around 60,000 crisis calls per year. And as I mentioned, that went up in 2021 to about 70,000, or fiscal year 21. So that's our July 1 to June 30th, to about 70,000. And then this last year we had nearly 100,000. So that's a significant increase in 2 years.
And do you expect that to continue to increase?
It's hard to anticipate. I think it really depends on how society continues to heal from some of the you know, different challenges we faced over the last couple of years. I think that's been a factor in driving those numbers up. I think there's also a lot more conversation about what does mental health look like, how and people being more willing to ask about these things. And I think we have a more aware public.
And I would
So
just add, not to interrupt Julie, because I'm mindful of time, that I just want to also highlight that I think across our full continuum, from hospitals to providers to the services that we even provide at the county, we continue to see also a rise in the polysubstance user, with kind of that common denominator really being a stimulant. And so, I think the other piece is that, as we think about the prevention pieces, also thinking about, how do we continue to evolve, enhance, and improve the treatment pieces, so that we can, increase the outcomes that we do see with our polysubstance user. And I know that, there are active tables that all of our local system partners are at, to look at how do we find some strategies and solutions. Before we move forward, Representative Nose, you had your hand up, or did you take it up? Okay. We're going to move forward. So up next, we're going to have a presentation from Robin Burke, who's the program manager for Portland Street Response, Jackie Thompson, who's the senior director for crisis services at Cascadia Behavioral Health, and Melissa Eckstein, who's the president of Unity Center at Legacy Emmanuel Hospital. I'll ask that everyone keep their presentations to about 5 to 7 minutes, so again, we can have a little bit of time for a dialogue before we then move on to the next set. Thank you.
Well, thank you so much. My name is Robin Burke. I'm the program manager for Portland Street Response. My gender pronouns are she, her, hers. Next slide, please. So I wanted to share a little bit about what Portland Street Response is and who we are. We are a multidisciplinary team that is we are embedded within the fire department here with the city of Portland. Our team is made up of an EMT basic, mental health crisis responder. This could be somebody who's licensed, or what's called a qualified mental health professional, QMHP. Or we also have another level of mental health professionals, QMHAs, which is qualified mental health associate. So this could be somebody with a bachelor's or commensurate level of experience in mental health. And then we also have an aftercare support team, and that's made up of 2 different disciplines. One is a community health worker, and the other is peer support specialists. These team members, these 4 team members, actually work very, very closely and very well together. Our EMT and our mental health responder are dispatched by the Bureau of Emergency Communications, also known as BOEC. And BOEC will dispatch us to calls. Sometimes our peer support specialist goes out with the team, and sometimes they roll off to provide that aftercare support. But our team members go to really 3 categories of calls. And all are considered non-emergent, non-life-threatening type calls. And that would be mental health, substance use intoxication, and general welfare check calls. About 75% of our calls are considered general welfare check calls, but they often intersect with mental health and substance use intoxication. When our team gets out there, they do an assessment and they'll introduce themselves. The majority of our calls, because right now our criteria is to only go outside, meet with people outside or inside businesses, the majority of the people that we get called on are actually being called on. They're not necessarily calling for themselves. And I think that's a really important differentiator in our program right now. And so part of that is just introducing ourselves and being as transparent as possible and letting them know who we are and what we do. And then we have an opportunity, as we build trust and rapport with the individual, and try to de-escalate whatever situation might need to be de-escalated, to get them connected to a community health worker or a peer support specialist who can offer case management support, connection to resources, and they can continue to work with that individual as long as they need to. We've actually only been in existence for 1.5 years, and we're currently scaling up our program. We'll be 24/7 by the end of this year. And so we're projecting to go on about 15,000 to 18,000 calls a year once we're fully scaled up to a 24/7 level. Next slide, please. What's working well? We have formed a lot of relationships with community agencies and grassroots organizations. We host weekly pop-up events for the houseless community at Lentz Park and at times at Gateway Park. We're also partnered with the University of Portland Nursing Student Program. We do a number of outreach events to try to get to community before the 911 call is placed. And then we also have a great working relationship with Project Respond as well. We typically lead on Project Respond if a call starts to escalate to the point where we think they might need to be hospitalized involuntarily. Our first responder referrals into shelters, this is something that was just recently set up for us just a few months back. And now for the first time since our existence, we've actually been able to get people into shelters. And I will tell you, my team feels so good about that. They feel like they are able to do something tangible in that moment. And they're so appreciative of the ability to do that. And then we're incredibly excited about the upcoming Beacon and the county's Behavioral Health Resource Center. I think that's going to be a huge aid to us as we are out there in the field, being able to have somebody taken or transported over to this resource center, get connected with resources. And we know that there will be also a behavioral mental health specialized shelter in more permanent housing. So we're eagerly looking forward to that. Next slide, please. Some of the challenges that we are experiencing, though, is that that resources, mental health, substance use, shelter resources, they're not readily available in the evenings or on the weekends. We know mental health is 24/7, 365 days a year. It doesn't have business hours, and that's a struggle for us. It's a real, our weekend team likes to say the weekend is a beast of its own to try to get through, because there's not many places that we're able to get people connected to over the weekends and on the evenings. The other part is with the, when we talk about substance use intoxication, just the lack of a sobering center that has a huge impact on us. But even going beyond that, you know, trying to get that seamless referral from sobering center to detox to residential treatment without a gap. What we find is that when we're trying to work with clients, there can oftentimes be such a wait to get into the next level of service that they fall through the cracks and oftentimes go backwards. So to be able to have something that would be more seamless in time with little wait time, that would be amazing. Next is to have more dedicated behavioral and mental health shelter space. Julie had mentioned in her presentation that 12 to 50% of those individuals living outside are struggling with mental health. And I think having more shelters that are dedicated to those needs would be really key. And last but not least, I mean, one of the things that's on my wish list is more respite services out there. So something that really falls between the crisis walk-in clinic that Cascadia has and then hospitalization. So respite centers would be a safe place that somebody could go to voluntarily. They'd be able to move in and out of that space, but it would be a safe space for them to address whatever crisis that they're experiencing in that moment. And so that's my wish list. But I hope that eventually we can get the funding for, and together as a community that we can start building together. But again, Beacon is really exciting. It's definitely going to fill a gap for us. And yeah, I'll go ahead and end it there so I can leave room for others. Thank you.
All right. Thank you all. My name is Jackie Thompson, and I use she, her pronouns, and my title is the Senior Director of Crisis Services. Next slide, please. I've put Cascadia's crisis services into 3 sections here to kind of describe them better. So we have our urgent walk-in clinic, which provides emergency mental health support for anybody that wants to just come in voluntarily. And we really want that support, right? If you want to come in, here's a place that you can go in voluntarily and receive supports. We also want to have mobile teams to go to individuals, which is our mobile crisis team, which is Project Respond, which runs 24/7. But I also wanted to highlight some of our specialty teams that are embedded within those, We have a family and child specialist team. We have peer supports teams, and then we have a couple of co-responding teams, which are co-responding in the way that they are clinician and police officers going out on calls together. And then I wanted to highlight, we also have outreach and engagement teams that are dedicated to that. We do have a shelter behavioral health team that provides mental health supports to anybody in shelter services in Multnomah County. We also have a team in the libraries, which is wonderful. We have an emergency department and a substance use diversion team. And then we just got really creative and have a mobile intake specialist with a collaboration with CCBHC. Next slide, please.
Can you just say what CCBHC is for those?
Yeah, see,
including.
I would, you know what, I just kind of blanked on that. But I can get those to you in just a mere moment.
Certified Community Behavioral Health Center.
Thank you.
Nicely done, Bob.
I've been there. I've blanked on that before too. So
Appreciate it. So I got asked what is working, which I do love to talk about. We have really dedicated staff in leadership in the roles that they're in right now that have been through a lot, as you could imagine, through the pandemic. And so the staff that we have and that are currently even being onboarded are really dedicated to this mission of crisis response for mental health. We cannot stress enough the resources that we've gotten and provided from the county that include a current expansion and ongoing collaboration. They are consistently, probably more than they need to be, available to me and my teams to really staff some very intense situations. And we just want to thank them for that. Cascadia has also done a lot of work to restructure their compensation to make sure that we've increased the wages for those doing this incredibly hard work. We have integrated peers into our crisis response. We've always had peer providers as a follow-up part of Project Respond, but we've seen a big need to also have them incorporated into that initial response. So we are currently in the midst of doing that now. We also have had really successful referrals to our sub-teams from Project Response, which includes aftercare for peer providers, our shelter team. So if we have somebody that's been able to get into shelter, we can send out our shelter team to provide behavioral health support. And of course, our child and family specialists for those that are considered youth. I want to describe what this looks like. We've had great referrals to outpatient providers that include Cascadia, but it looks like us calling weekly and seeing who's taking people and if there's wait lists and how long those wait lists are. But when they have openings, they are really working collaboratively with us to try and get people in emergency mental health situations into care. And I just want to highlight the collaboration with emergency services, including police and AMR. We have multiple meetings together, and they have also been very available to me with very complex situations that I have never seen until these last couple of years. So that's been incredibly valuable. Next slide, please. So the not so happy side is what's been difficult, which has been a lot. We have a very big increase in our call volume and a very big decrease in our staffing. Currently, for the amount of staffing we have, half of our positions are open. And that is, of course, a big deal when you're talking about a program that runs 24/7 and doesn't shut down. So you see us not shut down, but we are at capacity every single day because of staffing issues and increased volume. I will describe the increased volume as also an increase in acuity. We're talking about more calls that are describing aggression, agitation, weapons being present, assault happening, homicidal intent, paranoia, and distrust for others are the majority of calls that we're going on currently. And I want to highlight that that usually means that we have to bring law enforcement. And that, of course, needs a very thoughtful approach. And I highlight that because these calls also are taking longer times than we're used to. We would usually average about 30 to an hour for each call. And now our average is about an hour and a half. And of course, that's appropriate, but I just want to highlight some of those things that have been difficult. This also creates a lovely issue of a decreased ability for lower acuity calls. And I want to highlight that these calls are not, for lack of better words, inappropriate calls for us. We would want to go on these calls. These are calls where people are experiencing suicidal thoughts or homicidal thoughts, but they're lower on our acuity of calls that are just pending every single day for things that we would normally do because they don't have a specific plan or means to act out a specific plan, or potentially they have supports with them that are willing to stay with them until we can get there. These things are very difficult when you're just stacked up with calls every single day that are at that higher acuity mark. It's just so hard for us and our staff members to see these other calls we would want to go on, but can't because we don't have the staffing to do it at that day. And we're seeing more higher acuity calls that are, of course, needing a more emergency response than these ones. I also want to highlight.
Can I just ask, I'm sorry, thank
Yeah.
you. Can I ask a question about that? Do you coordinate with Portland Street Response, like to hand off those folks? I know that I'm not saying that that they're standing around doing nothing, because I know that they're overwhelmed as well. But some of those lower acuity calls, could those be passed? Is there some other?
Absolutely. Yeah, we take our calls from the crisis line, and of course we can go out directly if police call us, but the crisis line is doing everything possible. They know, we communicate with them daily about how many staff members we have, if we're at capacity, and they're looking for any resource, including Portland Street Response, who's been so great. And I know also has had backed up calls too, but yes, short answer is yes, we do. I would love to highlight substance-induced psychosis is definitely an increased concern, and to highlight what that actually looks like is individuals that meet our criteria even sometimes for a director's custody hold. So, really unable to track the conversation, they're not oriented, unable to safety plan with us, very loose association with reality, unable to tell me even where basic needs could be met. And so we're sending them to the hospital, but there needs to be a more thoughtful approach and look at what it looks like in the hospitals that are rightfully so put very strict definitions on if it's medical or mental health. And so as soon as it's labeled as substance use, it's labeled medical, and it goes to a completely different criteria to keep someone against their will. And so I just want to highlight that that is difficult on all ends. Here's somebody that isn't tracking, that's not trusting others, very fearful of others, making them very unsafe in our community. And there's this idea of what then do we do when they don't meet our criteria to hold them against their will, which is something we should think about. I also want to highlight that I have still been unable to access these set-aside beds, these first responder beds for shelter. And I'd love to have more communication, if we could, about accessing those beds. I know that they're very limited and totally understand that. But one of the difficulties working with individuals who, of course, don't have shelter, and also for us to be able to find them, is potentially accessing these shelter beds. Next slide, please. So I got asked the question, and I asked for a lot, so please take this with a grain of salt. But I got asked for the hopes and dreams. I would love to see some kind of mandates, and I labeled it as mandates because usually that comes with some supports. And I would love to see this idea that Julie already talked about, which is a collaborative approach that's required. This is an emergency situation. We should have requirements for shelter, for intake and assessment, for case managers, for middle term follow-up and supports. And I kind of described what I thought that would hopefully look like, which is reserved mental health intake slots with not just internally at Cascadia, which we have, which we love, but there's only a few of those. I would love to see reserved case management and care coordinators to help someone as they transition through that crisis. I would love, love, love these set aside shelter beds, because I'd also really like to highlight we need to support shelters in housing those individuals. And we already have a shelter team embedded in our system of care. So if I was able to get access to those shelter beds, we could have that team who runs 7 days a week follow up with that individual that day, the next day, and really provide those mental health supports that, of course, shelters are really desperately needing and wanting, especially as we're asking them to take on people in acute crises. And I would love to see some collaboration around supporting these emergency departments that have a lot of restrictions on and capacity issues of people that we are bringing to them. I would love resources and coordination for anybody that's discharging from the hospital that Project Respond has put a director's custody hold on. And I kind of had some ideas that I threw out there for that. We have an emergency team already embedded that is a diversion team, but if we could find more resources, they are qualified mental health associates, so undergraduate level, which means the majority of patients that they're seeing exiting have to be at a lower acuity level. And I think if we could provide some more resources for QMHPs so we could see higher acuity clients that absolutely are being discharged and really provide some of that follow-up support, that would be a dream come true. And I will pass it on.
Could I jump in and just ask a couple of questions, just because that, first of all, that was an incredibly provocative presentation. Thank you for that. Depressing as well. And at the end of this, I'm going to ask all three of you to talk a little bit about the staffing issue. But you mentioned that you've got literally half the staff that you need based on your current needs. And I know that all of our service providers, particularly in the mental health space, the substance abuse space, are struggling to find people at exactly the time that the curve is going up sharply in terms of the demand for these services. So maybe I'll just put the question out now and we can answer it later. What specific remedies do you think we should be working on collectively, and what should we be asking our good colleagues here from the legislature for in order to incent more people to come into these fields? Because this is becoming a very, very serious problem for us. And then just a quick question, you may not have the answer to this. You hinted at, well, you said that the acuity is increasing and it's increasing fairly dramatically. To what extent is that the result of some of these more dangerous substances that I referred earlier, like P2P?
I couldn't say. We don't track that specifically. We see substance use as something that when we do our assessment is a concern. And we do that very specifically, by the way. We do not want to label individuals as just substance use disorder. And I don't have to go into why we always be very cautious of that. It's a safety risk and concern, but we don't track exactly what they're using. So I wouldn't be able to tell you exactly what it's for.
Tracking that, or is there some reason we don't?
I
don't want to interrupt, Mayor, and I want to continue to make sure that we're responding to your questions, mindful of time, and I want to give folks a chance to answer your first set of questions too. And then I see Rep. Nose has his hand up. Sorry for interrupting. Please proceed.
Me?
Yes, go ahead, Jack.
Okay. I can say it's because of what it looks like in the field, Mayor. When I'm out in the field and talking to an individual who I suspect is under the influence, what you're getting into is what I would consider a medical question. I'm just asking, is the person safe? Are they not safe? I go into a tiny bit of medical, like, would you be willing to tell me what you've used just in case? It would be helpful if we got you to the hospital and they needed to know that. But mostly I'm just wondering medically if they're overdosing, and that's not usually what I'm seeing when I'm showing up or I'm calling, AMR and backup.
Thank you.
So yeah.
And I'll just jump in and then let others quickly answer the question, and then Rep. Nose, I'll let you ask your question. I know that there's a number of drivers that we're experiencing in terms of, what's kind of the root cause of the workforce shortage. And so, competitive wages is one. We walk through the Great Resignation as a result of the pandemic, in addition to starting to see baby boomers begin to step into retirement, and we're not seeing the same pace of individuals interested or curious or wanting to step into this work because of the complexity. And so that's one level of kind of core drivers that we experience in terms of why we're seeing this workforce shortage. And so then we think about, how do we get ahead of the curve by, starting to do in-reach into not the high schools, but the middle schools, the elementary schools. How are we also, as we think about vulnerable populations and as we're looking at it from a racial equity lens, how are we starting to more authentically partner with our BIPOC community to start to really bring forward traditional and promising practices of healing, to not rely on Western medicine. And then the last thing I'll say is another solution is starting to really expand at all levels of our continuum of care peer services. Rep. Nose, do you want to go ahead and ask your question?
Yes, and it was not my dog. I have cats. I was going to ask a question, but I think I'll just make a comment instead, which is it would be helpful to me if the presenters who offered all this insight into how our system works, this was a very solid presentation that you did explaining the ecosystem and how it really works. If there would be somebody that could put together a one-pager that says, this is when you should call 911, this is when you should give 988 a try, this is the difference between Portland Street Response, and this is the difference between Project Respond. That would help this legislator who gets calls from the public who want assistance to try to direct them to the right place. As I listen to this, and I think I didn't fully understand what I'm supposed to do when this situation presents. So I'll just leave my comment at that. And I'm enjoying this very much. It's been very informative.
Thank you. Thank you. Mindful of time, so Melissa, I'm going to hand it to you.
Thank you. Good afternoon, everybody. My name is Melissa. I use she, her, hers pronouns, and I have the honor of being Unity's president. And I appreciate the honor of being asked to be here today and to share with you all. Can you go to the next slide, please? Just a little bit of overview on Unity Center for Behavioral Health. We are a 24-hour behavioral health service that offers immediate psychiatric care and pathways to stabilization for both adults and adolescents that are in a state of crisis. We're a partnership between Adventist Health, Kaiser Permanente, Legacy Health, and OHSU. And a few little, I know the question's been asked a couple times around percentages of individuals seen that are primary substance use. And I do have a statistic on that. That is something that we track. We just had our 5-year anniversary in January of this year, and we've surpassed serving over 22,000 individuals since we opened Unity. We have seen roughly, roughly about 1,000 adults in our psychiatric emergency service, which we call PES, each month. 60% of those individuals are currently experiencing unstable housing when they come into us in crisis. 75% of those individuals are covered by some type of government assistance for their healthcare coverage, and 70+% have both some type of mental health condition that is combined with a substance use condition. We average seeing about 25 adults a day in our emergency room, and 80% of those are walk-ins. And that's actually a shift that we've seen from the time that we've opened. We think because of our location, but also because of where the community being aware of us, more people are walking in a moment of crisis. And a little bit about the services that we do provide. We do care navigation, counseling and therapy, crisis counseling and intervention, crisis stabilization. We provide inpatient care for both adults and adolescents, medication management, nursing care, peer support, social work, and spiritual care. 20% of the individuals that we see in our emergency room are transferred to an inpatient level of care. And on looking from a DEI lens, we're starting to gather more data related to this and should be able to provide more information in the near future. Vast majority of the patients that we serve are male and Caucasian. And as we continue to gather that data, we'll be able to share more. Next slide. Some of our successes and opportunities. One is that obviously the healthcare industry and providing crisis intervention here in our local community has changed many times over since we opened. And I think a success of Unity is that we have been able to maneuver that ever-changing landscape. We do have an expertise in providing care for those that are in a crisis and providing immediate short-term care meant to be 1 to 7 days. And we've renewed many connections between community partners. That's definitely a strength and a potential continued success for us. Some opportunities, I think it's important to mention Measure 110. I think it's a little too early to know what the outcome of that will be, but definitely something that we're looking forward to as a positive outcome for our community. Expanding substance use care in the upcoming year. We have lots of opportunity with some of the funding that's come into our state and local community. And I think there definitely should be a focus on peer-informed programming. And then there's been a lot of grassroots community work between our police department, the city, the county, and elected officials as we ease out of the pandemic. On the next slide, some current challenges and just talking more about what are some solutions around our current challenges. I think it's really important that we stay individual focused. I think it's really important to remember that when people are in crisis, it takes a lot of courage and strength to say that I need help and to ask for help. Currently, right now in our community, so much of our services are really focused on voluntary engagement, and we do have individuals, and this is a population that is the vast majority of what Unity serves, are individuals that really are not wanting to voluntarily engage in treatment, but need that treatment. Without that treatment intervention, they're not safe. The potential is there for them to hurt themselves or someone else in the community. For gaps, continue to see affordable housing, and that's, you know, whether it's a short-term or a long-term housing option, that's a huge barrier for us in being able to move people out of the emergency room and out of inpatient treatment. We're also seeing, you know, just the time to get people into any type of outpatient services. That's a huge barrier for people to be told that they have to wait 30, 60, 90 plus days to get into an outpatient appointment, especially when you're in a crisis, is just too long. Of course, you know, we're also seeing an increase in violence both inside of our hospital and outside of our hospital. Mayor Willer, you had asked just about engagement around workforce, and we're definitely impacted by a shrinking workforce. You know, Ebony mentioned the Great Resignation. We're not at the end of the Great Resignation, and we have not started to stabilize our workforce challenges yet. We have extremely dedicated staff that have made the commitment to want to work in behavioral health. And I think that it's something that we should all applaud, that we have as many staff as we have that have stayed working in the community and really want to be a part of continuing the hope for improvement in our continuum of care. I think it's important, you know, to point out that our staff are exhausted. There's a lot of emotional distress right now because we go into behavioral health wanting to help and connect people to the right services at the right time. And when our staff are not able to make those connections, or when they get told no, that someone doesn't meet the criteria for coming into services, or they're too acute for services, whether it's housing or outpatient services, it's very frustrating. I think that it's the staff don't feel like they're doing a good job. And I think that's led to a lot of people burning out and wanting to leave the field. I think we do have opportunities, though, in how we're helping people come out of programs and providing clinical supervision and support as they're learning their roles and learning opportunities. I also think that when our community sees the collaboration between all of us in the continuum of care, that's inspiring. And I think that it shows that we are focused on improving services and also trying to figure out where these gaps are and how to best help with the challenges that we're seeing. I think another area is we have some waste in how we're providing care right now. We need to look for efficiencies within the system of care. Many of us have talked about moving to one assessment tool. So right now you may have 4 provider points and each time you have to be reassessed. And to me, that's wasteful. When we have someone who's licensed that does an assessment, that assessment should be able to carry through regardless of whether they're seen in an emergency room or an outpatient setting. And I think there should be more discussions about how to make that happen. That's also multiple from a reimbursement standpoint. We're paying multiple times for an individual to have the same assessment in a very short amount of time. I think a coordinated mobile response and having a coordinated referral network is really important. It's as we're remembering to be individual focused when someone's in crisis, it's really important that we have easy access and that our coordinated mobile response has clear oversight, a singular oversight point. Lastly, I'll end with saying, that as a provider in the community, we feel strongly that we have accountability to our community and the services that we provide. And I think there really is continued hope through focused partnership, and we look forward to continuing conversations with everyone. Thank you.
Thank you, Melissa. I know we had kind of a short period of time for questions. I don't know if there's maybe one question before we move forward to make sure that our legislators can present any one quick question. All right. So up next we have Representative Sanchez and Representative Nos. Want to thank you for joining us. Want to thank you for your continued support, effort in moving the dial and helping to assure that we have resources locally to address the needs. And with that, we'll hand it over to you all for the next set of presentations. And just to forecast after this presentation, a couple questions, and then we'll hand it back to the chair and mayor to close.
Representative Sanchez, did you want me to go first and sort of describe at a 1,000-foot level what the legislature did in the short and long session?
I'm saying yes. Yes.
Okay,
sorry.
got you. Okay, very good. Okay. All right. So, so first of all, I want to thank the presenters that came before Representative Sanchez and I. I think they did a very good job of describing the sort of behavioral health system as it operates in our community. And I think you revealed in your presentation places where the legislature can hopefully help step up and partner. That said, I do want to reveal to people that are watching that the legislature is very deeply paying attention to this problem. 2021 and 2022 were historic sessions in the state of Oregon for behavioral health. We invested $1.2 billion statewide in trying to improve the mental health and behavioral health delivery system that we have, because we know we're struggling with all kinds of challenges. And we're well aware that we're 49th or 50th, depending on where you look, in terms of understanding where we rank relative to other places in the United States. I'm sorry that my colleague from the Senate can't be here, but like Rep. Sanchez and I were truly blessed in having Senator Kate Lieber in the other half of the building, because she had a journey in being on the Psychiatric Review Board. She brought a special kind of knowledge into what we're dealing with at the state level. The state hospital is an integral part, and our challenges at the state hospital are an integral part of what we're experiencing and what our public is seeing on the streets and the community. A couple of things I'll just highlight from that 1.2 billion. First is that we set aside $130 million statewide to stand up more residential treatment facility. And so think of that as not quite the level of Unity, not quite the level of the state hospital, but needing more help and support than just what you can get in an outpatient setting. We are, to be honest, struggling to get community partners and not-for-profits to take advantage of that offering of that kind of funds, but that is a critical piece that the state has stepped up to do to try to get more resources in this space. I was delighted to hear people talk about workforce. We passed a bill that Representative Janelle Bynum championed, House Bill 2949, to try to get more people into these fields, more non-white people to get into these fields, and to help cover the cost of scholarships, internships, getting the kind of education that you have to be able to do that. $80 million was allocated toward that, and I'm hopeful we'll allocate more in the next session. And then in 2022, very mindful of this workforce challenge. It was kind of like after we got done with the long session at the end of June, we almost started hearing immediately, we invested $1 billion, and it was like, what have you done for us lately because of the workforce challenges? And so we stepped up again. We found $132 million in House Bill 4004 to send to behavioral health providers, nonprofit providers that are not government-based across the state. And I know what we did worked, because I don't get a ton of emails where people write me and saying, Representative, I opened the email from hearing about the amount of money I'm getting from the state of Oregon, and the amount brought tears to my eyes, knowing what I would be able to do for my staff in terms of their compensation. And following up on top of that, that's just a one-time investment. We have most of these folks that you have heard who are in need of services or in the Medicaid system, and we have stepped up to increase the Medicaid behavioral health pay codes, rates, service codes by an average of about 30%, so that we can continue to pay providers enough money to be able to attract a workforce to work with these populations. That's not to say that we don't have improvement to make, but like I do feel like we've tried to be a good partner to you, Commissioner Chair Kafoury and Mayor Wheeler, as we know you're the ones sort of front and center dealing with this. I'm just going to say that I hear periodically from people that are concerned about ballot measure 110 and its implementation and its impact and how it's going. I think we all know the state has struggled to get that ballot measure implemented, but I think we're getting over the hurdle of the struggle. The money is going to start to go out the door, hopefully by the beginning of December, and we'll hopefully by this time next year begin to hear about the impact and the more people that have received treatment. I think, candidly though, the legislature and you all should partner with us about improvements we can make to that process, to the way that that money is allocated, and maybe even try to be a little more creative about how we could span some of the resources that ballot measure has provided into some of the more difficult to serve areas, including not just SUD, substance use disorder, but some mental health challenges covered by that cost, especially when substance use disorder presents itself at the same time. And I can't help but make a quick plug before I turn it over to my coworker. For people that are watching, ballot measure 110 is not what's causing the fentanyl, meth challenges that we're experiencing on our street. When I was in college, this word didn't exist in the 80s, conflating. It's a wonderful word. even if we didn't have ballot measure 110, we would be experiencing the fentanyl and meth problem that we're experiencing on our street. It's just that those two things are happening simultaneously. That doesn't mean that we don't have to try to get on top of what we're experiencing, but ballot measure 110 is not what's causing this. And with that, I'll turn over my code.
Okay, well, thank you, Rob, and thank you, everyone. I'm just so, I would talk mental health and addictions, behavioral health stuff all day long if I could. This is just truly, truly amazing. And I just want to appreciate all of the really amazing work that you all do. And again, all your presentations have been really, really important to sort of, I've got a whole bunch of notes here thinking about some of the different things that sort of different ideas and things that we missed maybe. As Representative Nose mentioned, we actually put a lot of resources together. We moved a lot of bills to move those resources and created some pathways for different types of things to support the behavioral health system. But we couldn't do it all, not right this very minute anyway. I do want to just address a couple of things that we have been able to do and or in the process of doing. And I will just also say sometimes it's really hard in the legislature. People, think we should be able to get things done really, really quickly and just make it happen. And it doesn't work that way, unfortunately. Moving resources, moving policy is a very, very difficult thing to do. You have to have a lot of coordination and a lot of agreement on a lot of people's parts to get things moving. And so it makes it difficult sometimes that it feels really awful sometimes that we can't change the things that we know need to be changed immediately. And let me just say, in the very beginning of the pandemic, actually in May of 2020, I spoke to Mandy Davis at Trauma Oregon, and we discussed the fact that we knew how bad this was going to get. And not just for a few people, it was going to get bad for a lot of people, and in particular children. And we discussed different ways that we would put things into place to try to figure those things out. And, obviously we're not entirely successful, but we're getting there. One of the things, of course, that came down in legislation on a congressional level was the 988 system, which is putting the ability for a national hotline number to be developed alongside something like, 411, 911, 211, all of those different types of things. They run out of 11, so we got 88, which is fine. But what that system was supposed to do, and it was implemented in July of this year, but what it is long-term supposed to do is to be able to provide an alternative or a way for people to get someone to respond to them immediately. And needless to say, we were not successful in bringing that money forward yet to actually, we did bring some money forward to set up the system, to start to set up. Not entirely. We still have to build a whole structure. So that bill will be coming in this next session to actually tax telecom, because Congress gave us the right and the ability to do it. And we're going to do it. They're not happy about it. And you probably won't be happy seeing whatever amount of money, it's probably, probably minuscule really, on your phone bill, on your cell phone bill or your other bills in order to stand up this system. But from my perspective, if my giving up, any amount of money on a monthly basis will allow someone to access a mental health services provider on the phone to help them walk through a suicide situation and live to see the other side, then I'm good. I'll pay the money. It just, that's just the way it has to be. So that is moving forward. I did also want to mention that we, in the 21 session, we moved House Bill 2417, which is the bill that actually allowed us to give some other resources to two cities and counties in particular to do some work around something like the CAHOOTS model, which of course we didn't want to be the CAHOOTS model entirely. We wanted counties to be able to build that themselves and do what worked for them, because what works in Multnomah County is not going to work in Jackson, right? It's not going to work in Harney County. It's all going to be different. And so we wanted to give those opportunities for that type of kind of building what works for our own community. I also want to note that this past year, I don't remember the bill number off the top of my head, but we moved the structure to actually be able to implement the opioid settlement resources. Now, those are actually, you all, Portland got, I think, their own allocation, but there will still be other resources that the state will have available to them. And one of the things that I think has been very, very important and want to really push when we start moving the opioid settlement funds is those detox centers. We have an extremely limited amount of detox centers, and we need to shift that. We need to change that. And we also need to have residential beds where people can go. This is not new information. All of us know this. When someone's ready for treatment, they should be able to access it. And that's not been happening for a very, very long time. And we need to change that. There are resources coming that we're trying to put into place. And it's just going to take a little while longer, unfortunately. And I hate to say that to you because I know it's very frustrating. But the legislature is really trying very hard to move some of these resources to put them in place so that we can change things, because it's very, very clear the pandemic didn't do much for us, but actually shine a hugely bright light on the deficits that we have in our behavioral health systems. So I just want to say, as Representative Nose noted for us, his work, Senator Lieber's work, Senator Solman's work, the work of many people in the legislature, actually, we're not blind to this. Those bills passed, they moved all of that billion plus amount of money into this work, and we're going to continue to try to do so. And I actually get to sit in a really great seat right now to where I can actually move some of those monies. So with any luck, we'll be moving them along, and your help in terms of really laying out kind of what's absolutely needed in the system is going to be invaluable.
Thank you, Rep. Sanchez and Rep. Nose. Mindful of time, I'd just like to also thank all of our speakers today. I think that, again, this conversation highlights the importance of synergy, trust, collaboration, and coordination as we move forward in enhancing and better meeting the needs of those that we serve, because we have to get it right, and we will get it right. I want to remind everyone that we will also have our next and final session on September 27th from 4:30 to 6 p.m. And a lot of this discussion will then guide some of the presentation that's upcoming. But I'd like to save time for the mayor and the chair with closing remarks and comments, so I'll hand it over.
And Ebony, real quick, there's a question in the Q&A at the bottom. I don't know if you want to read it out loud and have somebody answer it.
Thank you. Okay, so the question is, I would like to ask a question about how the city and the county and the state are going to address individuals who deny services. What kind of mandates and institutional structures will be put in place to meet the growing demands of the mental health crisis impacting our communities? Thank you for taking time to answer my question.
And when you say deny services, you mean people who are refusing to go to shelter, go get treatment? Is that what I assume that's what the question means?
Or is that service providers that are refusing?
No, I think the person is referring to individuals, the civil commitment issue.
Yeah, that is a very tough problem because you have a lot of competing feelings about that on all sides of this issue. The legislature, as long as I've served, about 8 years now, has taken that topic up every other time I have served and has not been able to find a consensus about how to handle it. And I will just also point out that if we make it, I'm going to use a slightly negative adjective, but easier to force somebody to receive treatment, we stress a system that you have already heard does not have enough workforce, does not have enough shelter, does not have enough services for the people that are presenting sort of wanting and able and willing to participate in what we have. And so that's not to say we shouldn't look at this, because I definitely hear about this from my voters, but it is a challenging topic when you talk about depriving people of civil liberties and maybe they haven't committed a crime, but they seem profoundly challenged by their mental illness or their drug addiction or both.
And can I just say there is actually, that conversation is happening. It's still happening.
And Julie, I see you have your hand up, and I just want to highlight that, this question also kind of centers the importance of why we have to continue to integrate and enhance and increase the number of peers into our continuum of care, specific to having someone walk alongside who can really normalize and encourage. Julie, you had your hand up.
I think I was just gonna say about the same thing, Ebony. I think we need to respect people's civil liberties, and we also need to find new and better ways to engage people who are frightened by the services that we offer. They don't want to be controlled, and that's probably the main thing that keeps them away. And so I think programs such as our Behavioral Health Resource Center will be opening in a couple months, and it will be peer delivered, where people can come and start to build trust, is a different way of engaging people in the opportunity to voluntarily go to the things that are scary.
Thank you. I'll hand it over for closing remarks.
I'll go first, and then Mayor, if you want to close us out. I just want to say thank you truly to every person who's participated in this today. I think it's been really, really eye-opening, and you've given us a lot of information, not just the highlighting some of the successes, but in some ways, more importantly, talking about where we can go from here. I want to reiterate what I said at the beginning, which was, in my 2 decades of service to this community, I have not seen the level of interest and coordination and cooperation from the state of Oregon that I have seen in the past couple of years. And that is due in no small part to the folks that we have on this call and Senator Kate Lieber. They've really, really doubled down on their efforts at the state level, which, as the mayor and I can say, our small local jurisdictions just are not capable of handling this all on our own. We've needed the state for years. I also want to say that I hope that today's presentation really makes folks realize the importance of coordination and cooperation in solving these very difficult and complex problems. And I look forward to the next time when we all come together.
Thank you. And I, first of all, just want to say I appreciate this collaborative approach, and definitely I hope that there's an opportunity for us to work together to center meth and substance abuse as part of this next legislative session, amongst all the other many, many important factors that were mentioned today. I really want to thank our incredible presenters today. You're just very thoughtful people, and you came well prepared, and I have a better understanding of the different parts of our behavioral health system, and I'm sure those watching online do too. And by the way, I want to thank everybody who's also watching online. It's also very good to see such strong leadership amongst our state legislators. Representatives Nos and Sanchez, thank you for being here today. And frankly, you've been with us all along and helping us to troubleshoot some of these issues and working with us collaboratively to talk about how we can solve this problem at the local level, at the county level, at the state level. As we collaborate on this issue at next year's state legislative session, I think we're all in agreement that we have to act with a sense of real urgency. I'm excited to hear more about your thoughts for the upcoming session in 2023. That will happen at our next public dialogue. Everybody's invited. That will take place on September 27th. I hope you'll all be able to participate. And Chair, thank you for convening this with me today. I look forward to next time. And with that, I hope you all have a wonderful weekend. Thank you.
Thank you, everyone.
Thank you. Good night.
Good night.
Thanks, folks.
Be safe.